Good afternoon, everyone. Thank you for attending our second webinar of the series, the NLCSP Lung Nodule Management. First of all, we would like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land on which the college is located. We acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. In recognition that we are a binational college, we take this opportunity to acknowledge Maori as Te Ngāti Whenau and Treaty of Waitangi partners in Aotearoa, New Zealand. Together, we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Maori health and education. Once again, thank you for attending the second webinar in our series. We have two fantastic speakers ready for you this evening. We will be opening with a presentation by Dr. Miranda Zimenowicz, followed by Dr. Sally Ayesa. Dr. Mark McCusker will be joining the panel at the end of the presentations, where we will have 15 minutes for any questions. So if you would mind waiting until the end, we will get to as many of you as we can. Please use the raise hand function if you do have a question.
Yeah, we'll have to.
All presentations will be recorded and made available via the College NLCSP webpage, which will be provided to you later. We ask that you ensure that your microphones are muted during the presentations. And now on to our speakers. Dr. Miranda Zimenowicz is a thoracic radiologist at Northern Imaging Victoria in Melbourne. She is chair of the Australian and New Zealand Society of Thoracic Radiology and is clinical lead for the National Lung Cancer Screening Programme, the NLCSP, on behalf of Ransker. Miranda sits on the LCSP Expert Advisory Committee and the Data Development Working Group for the Department of Health and Aged Care and is a member of the Lung Cancer Working Party of the Thoracic Society of Australia and New Zealand. At Northern Health, she is CT Clinical Lead and Director of Training. Our second speaker is Dr. Sally Ayesa. She is a dual-trained radiologist and nuclear medicine specialist. She works clinically at the Royal North Shore Hospital Nuclear Medicine and IMED Radiology. Dr. Ayesa is a senior lecturer at the University of Sydney Medical School, where she is head of speciality for medical imaging and is currently completing a PhD in medical education. She sits on several committees for Ransker and the Australian Association of Nuclear Medicine Specialists and has acted as lead for educational content development for the National Lung Cancer Screening Programme. And finally, we have also Dr. Mark McCusker, who will be fielding a few questions at the end. Dr. Mark McCusker is the Acting Deputy Director of the Department of Medical Imaging at the Royal Melbourne Hospital and an honorary lecturer at the University of Melbourne. Mark is a thoracic radiologist with interest in thoracic oncology, interstitial lung disease and cardiac imaging. He is a member of the ANSTER Working Committee Steering Group for the NLCSP. And with that, I will stop sharing and I will hand you over to our first presenter, Miranda.
Thank you, Liam, for that introduction. Tonight, we are talking about the National Lung Cancer Screening Program Nodule Management Protocol. We heard in the first webinar of the series about the ANSTER-RANSCAR Lung Cancer Screening Working Group and the national interdisciplinary collaboration that has gone into producing the wealth of materials that are available for the radiology workforce as we gear up towards the launch of the lung cancer screening program. We heard about the nodule management protocol and the way that it incorporates the PanCan risk calculator and draws from a LungRads-like framework which has been adapted for the Australian context. In a population-level screening program, we are targeting asymptomatic participants. For the purposes of lung cancer screening, this is defined as those individuals with no signs or symptoms of lung cancer. And this reporting approach in radiological practice requires a standardized approach to imaging interpretation that is perhaps even more key than it is in our routine clinical work. We know that structured reporting as a general principle improves report accuracy, improves clarity and readability, improves clinical utility and report completeness. And for the purposes of the NLCSP, that enables program monitoring and navigation of the participant journey through the screening and assessment pathway. Current evidence indicates that standardized structured reporting does improve reporting efficiency when put into practice effectively. The NLCSP nodule management protocol supports the radiologist's structured report, which is also mandatory for participation in lung cancer screening in Australia. It guides image interpretation and management recommendations and has been endorsed by the Department of Health and Aged Care. When a participant arrives for a lung cancer screening CT, they are imaged by low-dose CT according to the NLCSP acquisition guidelines out of ANSTA and RANSCA, and then the radiologist will interpret this scan using distinct algorithms for baseline and follow-up scenarios. And we need two different algorithms because at baseline, a nodule that is found on the CT has a lifespan that is unknown. It may have been present for 2 weeks, for 2 months, or 10 years. Whereas at follow-up, there is some nodule lifespan data available of variable duration. And those two scenarios mean that different tools are required to enact appropriate management. Both of these algorithms triage management using nodule malignancy risk according to the expected natural history of the nodule. And that's because nodules that look different grow differently. The PanCan nodule malignancy risk calculator, as we heard before, optimizes selection of low and high risk participants at baseline imaging, and that's where it's used. It's available browser-based, it may be downloaded, or it can be available in some automated volumetry software. And what it generates is a mathematical figure for a percentage malignancy risk for that nodule in that participant over the next 2 to 4 years. Here's an example of application of the calculator with a participant of arbitrary demographics. The family history of lung cancer is inputted by the radiologist. It's a mandatory field in the standard referral for low-dose CT for lung cancer screening, so will be provided to the radiologist by the referrer, usually the GP. The other metrics are the demographics and the radiological appearance of the nodule. And finally, this mathematical figure for a calculated risk of malignancy. That generated malignancy risk maps onto stratified risk brackets. So in the case of a 22% risk nodule that we've just seen in the example, this would generate a bracket within the 10 to less than 30% that in the nodule management protocol indicates that a 3-month follow-up CT is appropriate. These stratified risk brackets are termed in the protocol as numerical categories, moving from category 1, where we have these very low risk nodules, that also includes participants with no nodules or clearly benign findings, who all go to 24-month low-dose CT routine follow-up. Moving up through to category 5, which is this 30% or greater highest risk bracket according to the PanCan calculator, but also category 6, which exists to acknowledge the radiologist's expertise interpretation in synthesizing other indicators on the scan of high malignancy risk, be that post-obstructive atelectasis, lymphadenopathy, or frank metastatic disease. And both category 5 and 6 are recommended for referral to a lung cancer multidisciplinary team setting. The PanCan calculator was derived from the Pan-Canadian Early Detection of Lung Cancer Study screening data, which included more than 12,000 nodules and combined across the development and validation sets for the study. These were calculated out for solid nodules, part solid nodules, and non-solid nodules. But other nodule types exist outside that calculator. So what was not analysed in that major work is airway nodules and atypical pulmonary cysts. And these lesions are managed separately in the nodule management protocol and provided with specific guidance. So for example, an airway nodule that is segmental or more proximal would be recommended for category 4, 3-month low-dose CT follow-up, and that's to give it that short time interval to differentiate between a true nodule and retained secretions. Subsegmental nodules, smaller, more peripheral, category 2, 12-month low-dose CT follow-up. Atypical pulmonary cysts which are a more recently understood manifestation of lung cancer and have a variety of appearances on CT. When they're present at baseline, they're all imaged with an initial time point of category 4 3-month follow-up to determine growth trajectory. At baseline, and indeed any other imaging time point, findings that are likely to reflect infection or inflammation are denoted category 2, so-called incomplete study, because the entirety of the lung parenchyma has not been able to be assessed. They are imaged at a short interval follow-up that the radiologist elects between 1, 2, or 3 months as appropriate to the image findings, and are expected to resolve, at which time a full complete assessment of the lung parenchyma can be performed. Intrapulmonary lymph nodes are a further specific finding that are managed in the nodule management protocol with criteria. When they fulfill all of these, they can be confidently determined to be benign. We know that when they tick all of those boxes, they can safely go again to that 24-month interval CT, category 1, normal, nothing to see here. If a nodule is seen at baseline and then at its follow-up time point, it remains stable, the radiologist uses a technique called stepped management. Very simply, something that comes in at category 4, it was recommended for a 3-month follow-up, steps down into category 3 and stretches out the imaging timeline at every step. So we move from 3 months to 6 months, from 6 months to 12 months in category 2, and there's a single cycle repeated in category 2 to mimic that routine practice of lesions that we see in less than 2 years follow-up from baseline being imaged at shorter time points than those who have reached the 2-year mark that can be safely stretched out. So we do 2 12-month category 2 follow-up steps before we move back down into category 1. If a nodule is seen to be new or growing at follow-up CT, then management is determined by lesion morphology. And again, because we know that nodules that look different grow differently. So this is well-established evidence that we've had for many years, this graph from 2012 showing that separation in volume doubling time of solid pulmonary nodules and subsolid nodules, so meaning a combination of those part solid, so mixed solid and ground glass, and non-solid pure ground glass nodules. What's common across all of these nodule types is that we look at these lesions and triage them by their size and by their growth. So for solid nodules, the size criteria or the size thresholds that will determine different follow-up intervals will be less than 4 millimeters in size. If we're talking about millimeter, what radiologists will be most familiar using in their current routine practice, 4 millimeters to 6 millimeters to 8 millimeters and above 8 millimeters, and then triaging by whether they are new, growing, or slowly growing. And that will determine which arm of the protocol table that nodule will be guided by in the follow-up recommendations. Part solid nodules, again, look at their total size. So if the total average diameter of the lesion is 6 millimeters, then the total size is used to triage. But if larger than 6 millimeters, then we start being able to resolve that part solid, resolve the solid component of the nodule with enough accuracy to be able to drive management off measuring the solid component. So once it's of that certain size, we measure the solid component to triage management. And they are then also subcategorized by whether they're new, growing, or slowly growing. Non-solid nodules are triaged with a size threshold of above or below 30 millimeters mean diameter, and again, by their growth trajectory. So you can see the commonality here that the thought process behind applying the protocol is about seeing what you're looking at, what kind of a nodule it is, solid, part solid, non-solid, seeing how big it is, seeing where it falls into those different size thresholds, and then determining whether you're talking about something that's new or growing or slowly growing. Atypical pulmonary cysts have a variety of different manifestations on CT. They may be unilocular and thick-walled. They may be multilocular. They may have a dominant cystic component, but then with associated mural nodularity or peripheral ground glass opacity or consolidation. And therefore, the criteria for progression of these lesions is also varied. You may have a lesion that increases in its total size. You may have a lesion that stays static in total size, but the wall thickness increases. Loculations may appear in something that had none or may increase in number, or the associated opacities may progress in themselves. And all of these different manifestations of progression are managed in the protocol algorithms and guide different forms of follow-up. So we'll go through a few different examples just to get a little bit of a feel for how the protocol works in practice. So if we have, for example, a growing 15mm part solid nodule with a 3mm solid component. So that's a part solid nodule of a reasonable size. Once it's reached that reasonable size, we drive the management off the size of the solid component. In this case, it's 3mm. And this would marry up in the protocol with, as it turns out, category 4 3-month CT follow-up. And I don't want you to really focus on the specifics of these examples here, really just to get a feel for how it is that the decision-making works. So again, now we have a non-solid nodule, it's growing, it's 20mm in size, and that fits in the small threshold for non-solid nodules when you look down the protocol tables, and the appropriate follow-up in this case would be category 2 12-month CT. New loculations in an existing previously unilocular cyst are managed as category 4 3-month CT, with different manifestations of growth in atypical pulmonary cysts being either 6-month follow-up or requiring referral to multidisciplinary team meeting settings. So again, you're seeing just the way one particular manifestation of growth gets picked out in the algorithm tables, and will send you to a reproducible and easy to identify appropriate management interval. If you've got a participant who comes at second time point, so they've had one single CT in the lung cancer screening program previously and are now being followed up, say that they've been sent as category 4. So that's our worked example from the PanCan calculator that came out with this 22% PanCan risk. They got sent as category 4 with a 3-month CT follow-up, and now you're reporting the follow-up. You don't need to go back and look again and see what it was that sent them to category 4. You don't need to recalculate the PanCan risk and find out or confirm that it was sent through as a 22%. You're looking at the scan in front of you now, and you've received a nodule that is stable, was category 4, easy fix, now it's category 3, send them away for 6-month CT. So there's these different scenarios in the application of the protocol that trigger off these really quite stereotyped thought processes that are all incorporated into the guidance that exist in the protocol. The protocol is also accompanied alongside the algorithm tables for baseline and for follow-up with detailed explanatory notes. And these encompass definitions for using the PanCan calculator, so the definition of the method of measurement for PanCan, the location, the definition of speculation, everything you need to know to fill out, to calculate and generate that percentage malignancy risk. There is detailed guidance around the different methods of nodule measurement, noting that the recommended method for measuring nodules in the National Lung Cancer Screening Program is volumetry, with a generated volume in millimetres cubed. We know that this is the most sensitive for detection of growth, and it's the most reproducible between different observers. So we'll hear more about that in a different webinar, where we'll be able to deep dive into more detail around choosing and using volumetry software in your practice. Definitions of growth and slow growth are spelled out in the explanatory notes to again guide where we allow error margins and where we set the threshold for true definite change that requires action through the nodule management protocol algorithms. There's also guidance for managing irregular imaging intervals when taking into account prior imaging that may be made available outside the lung cancer screening program for comparison, or in the case of missed or delayed screens for participants in the program. So In summary, the National Lung Cancer Screening Program Nodule Management Protocol has been developed by Australian chest radiology expertise. It is endorsed by the Department of Health and Aged Care. It supports the mandatory structured report that will be in use for the program, and has algorithms for baseline and follow-up scenarios that use the risk calculator or nodule morphology, size and trajectory to apply predictable and reproducible unified management recommendations for different participants at all time points in their participation in the program. It's a tailored, comprehensive and self-contained tool to guide radiologists and support them to deliver this essential service. ANSTA looks forward to closely following the performance of the protocol in the real-world setting and incorporating evidence as it emerges into future iterations of the protocol. Thank you very much for your attention, and I'll hand you over to Dr. Sally Ayesa.
Thank you so much, Miranda, and thank you to RANZCA and ANSTA for bringing me in to be part of this program. It's just been an absolute honour to be able to work on the implementation of the National Lung Cancer Screening Program from a radiology educator perspective. It's been particularly special. So I'm joining from Daro country in northwestern Sydney. I'd like to pay my respects to those who care for and continue to care for country. And today we're going to just kind of have a bit of a whip around of the hero of the National Lung Cancer Screening Program, which is the nodules themselves. And so what we'll be looking at is some of the imaging features that you will be looking for, particularly with that PanCan risk calculator, as Miranda's gone through, and then also some of the higher risk features which may impact how you categorize the nodules. So we're going to have a look at cases of solid, non-solid and part solid nodules, while taking a bit of a detour into juxtapleural nodules and how they may manifest on imaging, and then coming down to airway nodules and atypical pulmonary cysts, which from an education perspective, with looking at this program, noting that we're all radiologists, we've seen pulmonary nodules before, we're hopeful that through the workshops, through the online modules, there's going to be quite a focus on these kind of less common nodules that we see, so airway and nodules and atypical pulmonary cysts, so we can all kind of work on upskilling as we start to embark on this screening journey. So really what we're trying to do is determine which of these pulmonary nodules are required for follow-up and which we can consider benign. So with the pulmonary nodules for follow-up, we're going to be triaging them using that PanCan risk calculator and then coming down on that management recommendation. So for those nodules that are considered benign, particularly we'd be looking at nodules with benign features or juxtapleural nodules. I'm just going to, just reframe my screen. So starting with our definitions of solid, non-solid and part solid, and we'll race through because Miranda's already covered a lot of these, but here we go with our solid nodules. And these are those discrete densities. They are well defined on imaging and then our non-solid, our ground glass nodules as we see here, and our part solid nodules, so mixed ground glass with that solid component. Starting with our solid nodules, we're going to be assessing these in terms of their shape, so round, oval, lentiform, triangular or polygonal, in determining whether or not they are nodules requiring follow-up or nodules which we can confidently consider as benign. We further look at the border and the margin, and with spiculation, something that is within the PanCan risk calculator that we want to try and identify with these nodules. We consider the relationship to pleura and fissures, internal calcification or fat, which may indicate a benign morphology, which is not covered today, but will certainly be within the online modules, and then considering those neoplastic and benign causes for these. So this is our little detour into juxtapleural nodules, and the definitions here are quite robust. Juxtapleural nodules need to be less than 10 millimeters and of that real typical morphology. They can be in any location in the lungs, provided they're contacting the pleura, but if they're in the right middle lobe or the lower lobes, they can be within 15 millimeters of the pleura. So there's one there, nice triangular morphology. We can see the fissure coming through. And so if these are seen at baseline, these can confidently be categorized as a category 1 with a 24-month low-dose CT. So coming back to this though, with our morphology and thinking about shape, not every round nodule is going to necessarily be a juxtapleural nodule, and we need to look at other features, including that relationship to the pleura, the distribution, and the border. Because in this case, we've got two rounded nodules here, and here. And then we've also got oval nodules as well. So here's one here, and then another little oval one, which nicely kind of contacts the fissure. And so working through these is really important because these are two examples of early lung cancers, and these are two juxtapleural nodules. And it's okay if you aren't sure. It's always best to kind of, up categorized, but if you can confidently diagnose them as juxtapleural nodules, it's worthwhile doing so. If you're seeing nodules and describing them as triangular or polygonal, like this one here, here's a nice triangular subpleural one, here's another one here, then these can be confidently diagnosed as juxtapleural nodules, and both of these are intimately related to the pleura, as we see. So coming back to borders, and the spiculation is a particular point on the PanCan risk calculator, and here's a nice nodule with a spiculated border. So I think we're asking ourselves, is it smooth, irregular, or spiculated, with those spiculated borders increasing risk? And as per the explanatory notes within the protocol, the spiculation has a very particular description and definition, which is multiple linear fine strands extending from a nodule to the surrounding lung parenchyma in a stellate manner. So here's a few different examples of what that might look like. So you can see through here, we've got 5 different nodules, which all have spiculation and some high-risk features. We'll just let the animation play out. You can see the borders on these particular lesions coming through. And even this one, even though it's related to the fissure, it's distorting it rather than abutting it, and just kind of as a bystander. So taking these off. And I really like these kind of 5 cases as well, because as we just saw with that last case, actually 4 of them demonstrate a relationship to the fissure, which is causing that distortion and that retraction. Now, relationship to the fissure and this retraction is not part of the PanCan risk calculator and is not discretely part of the nodule protocol. But however, it is within our gestalt as radiologists to increase the risk category of that nodule and consider it a high risk feature. For example, if you're determining whether or not it could be a juxtapleural nodule or a malignancy that's doing this by pulling it in, then you would certainly feel more comfortable upstaging it and categorizing it appropriately. Here's a nice little example, another nodule which is pulling the fissure. And so considering that relationship and that location relative and that distortion and irregularity and retraction would certainly make you more suspicious that you're dealing with a clinically significant nodule that requires management. Just a nice example of slow progression as well. We saw about how we're comparing over time these nodules and looking for growth patterns, and this is a nice example of a small pulmonary nodule from 2012 to 2017, which has demonstrated slow growth. Would we have called this on the 2012 scan? Perhaps not. It certainly wouldn't have been given a high risk categorization, but that regular screening interval within that two-year period, we would be catching that on subsequent scans and then referring for follow-up. Moving on to our non-solid nodules, these are typically circumscribed and less dense and hazy. You can really see the normal lung structures through them. So the interstitial structures, the vessels, the bronchi. I was taught when I was learning that it's almost like looking through a foggy shower screen or a shower curtain. These require really careful evaluation, looking for that solid component. And so non-solid is those typical very pure ground glass. Once you're looking at finding a solid nodule within it, then we classify them differently as those part solid nodules, which we'll get to in a moment. And continuing on with our theme in terms of the slowly enlarging nodules, we can see exactly the same for ground glass, and they can even become more conspicuous over time. So this is a 10-year imaging period that you see as just a very poorly defined ground glass density here in 2013, and then moving on back to 2021 and through to 2023 as it becomes more conspicuous and enlarging in size, which would be caught as a slowly enlarging nodule and then categorized appropriately as per the calculator. Here's another one again, just a nice example. And it's also got a few bubbly lucencies and air bronchograms as well, which seen within can also be a higher risk feature within our nodule. And over 26 months, you can see that it's now kind of declaring itself. So it would require a higher category of management. And there, this is just another example. I know that this isn't particularly ground glass. It's a little bit more of those consolidation kind of malignancies, but it was just a nice example of those bubbly lucencies seen within, which can predict lesion growth. And just a few nice examples of air bronchograms. Here's more, a dense consolidation with air bronchograms. This was a cancer, and then that pure ground glass with an air bronchogram seen within, and that increases that risk of invasiveness. And so you can use your Gestalt as a radiologist to impact that categorization and make your decisions. So for our part solid nodules, they're ground glass with that solid component, that higher density nodule within, and with that it carries a higher risk of early carcinoma, with that solid nodule often indicating that's the higher grade of component. Particularly, these are very typical of adenocarcinomas. So you may have a lipidic subtype, which is accounting for that ground glass, and then the higher nodule, the higher grade component, if it's dedifferentiating or changing, is often that solid nodule. And we'll see a case in a moment of kind of how that solid component can sometimes grow and overwhelm it. Just a little bit of a pearl though, with between the lung window and the soft tissue window, if you put on the soft tissue window, you can actually kind of get a greater sense of that soft tissue or that more dense nodular component here on the CT. And there's that case I was looking for. So this is a larger subsolid lesion, which demonstrates the more central component, which is kind of has that greater density and then surrounding ground glass. And then over time from February to May, and then coming up to July, you can see that that ground glass has been overwhelmed by the more solid component, where you're ending up with this more area of solid mass within the lung, which heralds that progression of this particular lesion. So moving on, we're going to finish up with airway nodules and some examples of atypical cysts before we move on to questions. So with airway nodules, the big question is it a solid or soft tissue lesion, or are we looking at mucus, as Miranda has already alluded to? If you see bubbles within, you can confidently say that that is mucus within the airway, and then you can move on, but you can't always determine whether this is tissue or not. And it's really tough, which is why this is inbuilt into the protocol with really clear guidelines about when they should be coming back for follow-up imaging. The anatomical location with the protocol is going to determine that management recommendation as well. So knowing your bronchial anatomy and so more proximal segmental to subsegmental moving out through the lung is going to be really useful in assessing these. And this paper was just so nice. This is from the American group. Showing the range of different airway nodules. And, some of them are more, frankly, malignant. Some of them are looking more benign. But you can see that there's a range of appearances and that it can occur anywhere through the lungs. What I like about we'll come back to these ones which are more solid and persistent over time, and then kind of these arrows through it. But some of them are more mucoid secretions as well, and some of them you just don't know. So you bring them back for progress imaging and see how they change over time. These ones here are quite nice examples of bubbles within the mucus. So you can see that with those low density areas within, when you look on your lung windows, those bubbles within, you can confidently call that benign, and they don't need to come back. So but finishing up now with atypical pulmonary cysts, which, as Miranda has already alluded to, is a really new kid on the block when it comes to lung cancer, but is now and has been a recognized manifestation, particularly of lung adenocarcinomas. And there are some features which allow us to stratify them as higher risk. But we will kind of just start with what a simple pulmonary cyst looks like. It's that round air-filled space lucency. It's a thin epithelial or fibrous outer wall, and it's well defined with the lung, and it's uniform. So it's very thin. So there's no thickness, there's no asymmetry, there is no nodularity to these simple pulmonary cysts. And we contrast this with atypical pulmonary cysts. And up to 9.3% of lung cancers have a cystic component on their initial imaging, and we can look for those suspicious features, and this is built into the protocol. This includes things like a thick wall, an asymmetric wall, an associated nodule, or internal septation or interval growth over time. So let's look at a few different cases, because these can have quite a variable manifestation on imaging. So here's some examples of a thickened or asymmetric wall. And you can see here it's more thickened at the lateral and the medial border of this lesion. Here it's more thickened through the middle. Here it's even more ground glass and kind of irregular at that lateral border and barely perceptible medially. These are some nice examples of internal septations, and you'll see I'm using the same cases, but it's just because they often have multiple features here which will allow you to be more confident in your diagnosis. So these septations, let me take off the animation. You can see, sorry, I'll just go back. Apologies, I'll go back. There we go. You can have a real look at that morphology and see the internal septa through, which then allows you to classify that as an atypical pulmonary cyst. Here's another nice example from one of our articles, which demonstrates here those thickened asymmetric walls, and then that nodule here at the border. So let's have a look at another nodule. And I really like this case because it demonstrates the growth of that nodule over time. So here is our atypical pulmonary cyst, and I'll bring up the 3 images over time. So there we've got, just at the very first imaging, we've already got a few concerning features. So thickening of the wall, there's asymmetry. This wall here is thicker than this wall here, so we're a little bit worried. And there's more nodular thickening, but over time that nodule grows until on our final image it's very measurable and it's no longer equivocal, and that cystic component is less prominent within the lesion. And this is quite a typical appearance of that natural progression as the lung cancer grows over time. Following up with just a couple of cases of mimics of atypical cysts, because not everything with gas in the center is an atypical cyst. So cavitary nodules are not atypical cysts. Here's an example of a lung cancer, which we saw earlier with that spiculation. It's a very thick wall, looks almost donut-like, irregular cavity. You're not really seeing well-defined walls. And this here was a necrobiotic nodule. But I think if you were to see this on a screening situation, you would be classifying it as a nodule for follow-up. You wouldn't look at that and go, oh, that's a typical necrobiotic nodule. That's not how it works. So you would follow that up. Then also fluid-filled cysts. So we're going to be, by nature of the screening program, we're going to be looking at patients who are smokers, long-term smokers. So they could very well have long-term, they could very well have very severe or established emphysema. So infected bullae or fluid-filled cysts are certainly something that you may come across. And this would be considered as incomplete because it's an infectious etiology or an infectious or inflammatory etiology. And then looking at air bronchograms within a spiculated lesion here, this was a case of lung cancer, and this would also be considered as a nodule for follow-up. And so that brings us to the end of our very brief whip around with some cases of what you may be encountering in the lung cancer screening program and those features that we'll be looking at with the nodule protocol. With that, I'd also like to invite anyone who is interested in joining the ANSTA mailing list for updates, please join us with the QR code, and I'll hand back over to Miranda, Mark and the RANSCA team so we can look at questions.
Great. Thank you very much, Sally and Miranda, for those presentations. They were fantastic. We'll now open the floor for around 15 minutes for questions for Miranda, Sally and Mark. Please raise your hand in the Teams function if you do have a question, and we will aim to get around to all of you. So please work away.
One question that just came up in the chat during the talks was from Xavier Yu, who was wondering why is there a difference between the definition of intrapulmonary nodules for the upper versus the lower lobes, which is a very good question. I've put a link to the paper that guided us in defining our definition for the features of intrapulmonary lymph nodes, which is basically what we're trying to exclude from follow-up. Most intrapulmonary, the studies that have been done on these demonstrate most intrapulmonary lymph nodes occur in the lower lobes anyway, so they're way more common in the lower lobes. And most missed cancers that are thought to be lymph nodes but are actually turned out to be cancers are in the upper lobes. So that's why you've got to be a little bit cautious about the upper lobes, and that's why the definition is a bit more restrictive for upper lobe versus lower lobe periphyseal and subpleural nodules.
Thanks, Mark, and thanks for popping that link to the article into the chat for everybody.
Any other questions?
The nodule management protocol itself is endorsed by the Department of Health and Aged Care. It is finalised in terms of its clinical guidance, and we await legal from the department's end in terms of tying up copyright implications before we're able to publish the completed version for everybody to start familiarising themselves with. But we anticipate that very shortly. We're very excited to send it out in the world. So watch out for it soon. It's not far away. it's a nice opportunity for me also to just thank everybody who's on the ANSTO RANSCAR Lung Cancer Screening Working Group Steering Committee in particular, and the working group as a whole for all of the work towards the materials that we have and are beginning to release now. The low-dose CT acquisition guidelines are about to go out. Liam, I believe your finger's on the button to put them up on the website.
Yeah, ready to go.
So that's exciting. That's the first cab off the rank. We're expecting the nodule management protocol very soon. The additional findings guideline is a guideline that's been developed to manage standardized recommendations for common, significant, actionable findings seen incidentally on low-dose CT for lung cancer screening, and that's undergoing public consultation at the moment. So if you go to the NLCSP website for RANSCAR, you'll see that document there if you want to have a look through. It closes at the end of the week for public consultation. Everybody's welcome to review and feedback. And we've got a question from Anthony Falber. And you're on mute. Go ahead.
Sorry, I'm not sure. Hopefully, I'm unmuted. Yeah, good.
I can hear you.
Thanks for that. Fantastic cases. There are patients who turn up, or people that turn up for CT chests, who are asymptomatic, yet they've got pulmonary fibrosis, and some of them have actually got UIP, but they've just walked through the door. One of the cancers I've missed along the way is someone with honeycombing. Amongst the honeycombing, had an atypical cyst, which is just almost impossible to see. So as soon as, if they turn up with other significant respiratory findings, are they booted out of the program? And no, they're still in the program.
That's a really good question. So reasons for exiting the program. There's a question in the chat as to who qualify for lung cancer screening. Reasons to be in the program is age 50 to 70 years old and a smoking history of at least 30 pack years, either actively smoking, currently smoking, or have quit in the last 10 years. So those are the criteria. Criteria to exit the program is either aging out or having an active diagnosis of lung cancer or being actively worked up for a possible diagnosis of lung cancer. Otherwise, everyone is welcome as long as they meet so-called suitability criteria for undergoing low-dose CT. Suitability means they can lie flat for 5 minutes to undergo the scan, that they haven't had a lower respiratory tract infection with significant symptoms in the last 12 weeks, because we know that those people will have those transient category 0 findings and will end up getting unnecessary repeated scans. So we want them to pause until they come back, or a weight that exceeds the scanner limits to actually be able to undergo the scan. Anybody who has these kind of significant incidental findings will continue to come through the program. They just need to have no signs or symptoms of lung cancer. So we are going to be hunting through these fibrotic lungs for lung cancer, which is a good thing because we know that the relationship between smoking history and fibrotic lung disease is at least additive in terms of increasing the risk for cancer. So we certainly welcome everybody to come and bring their fibrosis for screening.
And we
Mark's
also
got your hand up.
Yeah, I was just going to add to that. There will be guidelines for additional findings coming up as well. And interstitial lung abnormalities, airway disease, et cetera, will be included in that too, about, what we're recommending for general radiologists to try and guide that process. Because, I mean, obviously, interstitial lung disease is something that not everyone is going to be very familiar with. And we're going to hopefully make that a bit easier with the additional findings guidelines. And
that's the guideline that is open currently for public consultation. That's closing on Friday. Yep. So you can browse the current working draft, but we are still expecting feedback from multiple different key stakeholders. The draft that exists has gone around and received input from key groups, Thoracic Society of Australia and New Zealand, interstitial lung disease experts, cardiology input. We've had a lot of key expertise already that draft, and we hope to refine it and mature it out and finalise that over coming weeks. We've got a question from Amy Baker.
Yeah. And I'm sorry,
yes,
just
hi,
before.
Thanks so much.
Just before Amy jumps in as well, sorry, there was a question in the chat about the eligibility, so I've just popped that up on the screen and I'll take that away. Sorry, Amy, to interrupt you. I'll let you go.
No, thanks very much, Sally. Go ahead,
That's
Amy.
all right. Thank you so much. I've got two questions, actually. One of them is if you issue a report and you give a nodule a baseline, a relatively high risk of malignancy requiring sort of more active follow-up or referral to MDT, and then you get a previous external CT from, say, 4 years ago that demonstrates the nodule to be stable, is there a mechanism for revising our original categorisation? Or I was just wondering how that would all work.
Yes, discrepancy and amendment feedback to the National Cancer Screening Register is an active question. So that's on everybody's radar, that kind of functionality needs to exist for exactly that scenario that you've described. So all reports produced for the National Lung Cancer Screening Program will get returned to the referrer, just like we would return any other report that we produce in routine practice, but they will also be provided to the National Cancer Screening Register, which currently houses the cervical cancer screening program and the colorectal cancer screening program. So it's now being built out by 50% capacity again to house lung cancer screening. So everything that we produce in that structured report goes back to NCSR, and the report forms the significant data fields for the register, and anything that we change can then be added and supplemented into the register. So yes.
Thank you. And I have one more question, if that's
please.
All right.
Yep.
I was just wondering, with those extremely slow-growing ground glass lesions that may not change very much over a 2-year period, will part of the reporting process be that they need to be not just compared with the most recent previous, but with baseline as well? Because I'm only familiar with one form of software, an AI software package that compares lesions, and they only compare the current with the most recent previous. So I was just wondering how that was going to be sort of worked around.
Yes, absolutely. It's a very relevant question. So the short answer is that slow growth is critical, and a lesion can absolutely grow within error margins and never meet criteria for growth. But when you compare this scan to the most recent prior, but will meet criteria to the older scan. But I'll throw to Mark, who has been a big player in looking at the definitions of growth, and you might want to elaborate yourself as well.
Yeah, thanks for that. No, that's a really good question, Amy, and that's gonna really, it's critical to look at the oldest scan for all of those, which might make some AI platforms, less useful than others. Just regarding your first question about extra information, extra scans becoming available, you might encounter a situation where you look at a CT, you report one CT at baseline, you think it's suspicious and refer it to an MDT. The MDT then might uncover older imaging from 5-10 years ago and decide that it's been there for a long time and unchanged. And what will happen in that scenario is then the MDT is responsible for referring back to the program with a report of how they reached their conclusion, so that hopefully then the next time you see that scan in the program, you'll have the information from the MDT that previous imaging was available and that nodule has been proven to benign, even if you don't have the very old scan yourself.
Thanks, Mark. Sally, I'll go to you.
Sorry, I was just bringing up that there was a question in the Q&A section of the chat from Manish Khanna, and they've asked, does different breathing phases cause significant difference in the nodule size?
Yes, is the answer. Yeah. So they've done what they call coffee break studies, where you scan a patient and then let them go have a coffee and scan them again. You can get quite big nodule variation, up to 15-20%. Which is why if you're measuring lung nodule volume, we in the program we won't be defining a real change as anything less than a volume. Anything less than a 25% change in volume, the program defines as stable. And for true growth, in the program, you need to demonstrate that something's increased by over 25% in the volume. But yeah, phase of breathing, level of hydration, all sorts of things can cause differences in the size of nodules in the same patient.
Thanks, Mark. There's another question from Ross Bredmore in the chat. How is this program different to the other international lung screening programs? Major differences, and will the information be shared? The major difference between the NLCSP and the majority of international programs is the scanning interval for those participants with low risk or no findings, which is the 2-year time interval. So LungRADS is a very, very common framework that's used internationally in multiple parts of the world, and that uses an annual follow-up interval. So that's the biggest difference, and it has implications on all of the definitions and all of the safety net that we have around different findings. And that has what has produced the most, sort of triggered the most evidence review, triggered the most investigation and testing and interrogation and thought as we've adapted that framework to the Australian setting, because we know we don't have the safety net of an annual cycle. We've got a 2-yearly cycle. That also has implications for the way we look at additional findings, because the quick reference guide for additional findings that supports LungRADS again has recommendations that assume that the participant is coming back in 1 year to look at whatever it was in whatever other part of the body outside of strict lung nodules. So the incorporation of the PanCan calculator is also uncommon around the world. So it's used in small centres, in sort of small scale screening programs. So in British Columbia, it's used as part of the basis of their calculation, but it's also a very widely known and an understood tool that's been validated in large-scale studies. It is referred to as a useful tool in the LungRADS framework, but it's not baked into the protocol the way that we've been able to leverage it. And we specifically leverage it for that ability to isolate out those low and high-risk participants. So participants who have that less than 1.5% PanCan calculator risk, or those with no findings at all, account for 75% of anticipated participants, and that's based on Australian data from the International Lung Screening Trial, so a large-scale study looking at more than 4,000 participants. So we know that we're going to find 75% of people that we can use half as many resources to safely rescreen them and have half as much intrusion and ancillary costs in their lives to participate safely in the program. We also know that we can send half as many people to MDT workup for suspected lung cancer for the same number of lung cancers detected. So it's from around about 7% goes down to just under 3% of all participants expected to be isolated out in that category 5 or 6. So really quite profound resource implications that mean that we can capture political will and leverage the real financial restraints of the Australian setting and roll out a program when so many countries around the world are without funded, centralised, free to participate national coordinated programs. So we're in a very enviable position in Australia. We'll go to Tom Snow.
Hello. Thank you so much for a very interesting session and beautifully described. Thank you. Overall, you all ought to be congratulated for turning the program into something which is becoming more usable and friendly for radiologists. And we are the professional group which is most impacted by this program. There'll be some impact on the thoracic physicians and the surgeons and whatnot, but the bulk of the work is going to come to radiologists. So I think it's really impressive that you've managed to turn the focus of the program onto making so that the radiologists are going to find this easy and enjoyable as much as they can. So many congratulations about that. And this may not be a question for you, this might be a question for the thoracic physicians, but I think there's going to be some problem with people who won't adhere to the program. So you tell them that they've got a nodule and that it needs 6-month follow-up, but they won't accept that. Is there any plans for dealing with those people?
Yeah, that's a really good question. And firstly, thank you for your kind comments. the question of loss to screening and failure to follow up is something that's really key in any kind of population level program. It's something that is a particular challenge in a lung cancer screening program, because we know that there are multiple layers of stigma and barriers to participation in a population of individuals who have a history of or who are currently smoking. There's fatalism, there's distrust, there's fear of being lectured, of being reprimanded, of being held accountable for whatever might be found, so therefore why look for it, and just not wanting to be lectured about what they've done wrong. So that plays out, that we see this play out on an international level. We know that in Australia, for example, the participation rate for the breast screen program is around about 50%. So people who are eligible for breast screen take it up, 1 in 2 people. The participation for the colorectal cancer screening program is 41%, and you've got to gather your own poo to do it. Whereas the international range of rates of participation in a lung cancer screening program, where all you have to do is lie down and get a 5-minute scan, is between 5 and just over 20% of eligible participants. So we're very, very well aware of all of these barriers to participation. In Australia, we have a very enviable position in that we've built the program on the back of a huge amount of implementation science, which has gone into developing the materials and the approaches and the strategies. We have scientists at the University of Melbourne who are central in program design, who have been leading international multi-centre studies in terms of determining how best to overcome these barriers, how can we identify them, and how can we tailor the approach in the Australian population. It's also something that's very at the forefront of the federal government as we roll the program out, and the program monitoring metrics that will be used will be looking at where people drop out and trying to determine why. So as we review the program, which comes up for review 2 years after launch, we're going to be looking at all of these things that contributed and how we can tighten and how we can retain people and how we can extend the spread of this life-saving intervention.
Okay, so I was alluding really more not to people who drop out of the program, but people who refuse to accept the weight. So in the past, we've had people who were told that they had a nodule which needed yearly follow-up, but they insisted on having a bronchoscopy or having a biopsy. I've come across both of those circumstances. And I think now in the context of a national program, that bronchoscopist or that radiologist who does a biopsy on a patient who is off protocol for the screening program, everybody should know that that's unethical.
Yeah, I think that's going to be very much discouraged. And we're also, if you interventional procedures aside, if people show up too early for their follow-up scan, it actually means you can't apply the protocol properly because you haven't demonstrated long enough periods of stability, for example. So it's very much discouraged in our protocol. And that's the message that we're going to be sending to GPs is the time durations are there for a reason, and please don't send your patients any early. We can't really completely mandate that it's not allowed, because there obviously be edge cases where people are going on holidays or whatever, but it's discouraged, and I think that's as much as we can do at this point.
Okay, thank you.
Lung Foundation Australia is responsible for developing the suite of education materials that will be available for GPs to understand how to utilise the program and what are the critical touch points in the program. And ANSTA has consulted on those materials and has been given the opportunity to provide that messaging along with other radiology mission critical messaging, so that GPs really understand where we're coming from and understand the sort of key factors in how the program functions and what might affect it. We'll go to Andrew Ha.
Hopefully you can hear me. Thanks for your talks. Just I know it's close to finishing time. Just quickly, in an ideal world, we would have access to all the prior imaging, but the reality is that people go to different locations, different companies. Are we going to be having comparisons with just the data recorded by the previous round, or will we have access to the prior imaging if they're going to different venues, or is it going to be a centralized database for all the imaging?
There is no vendor-neutral archive for imaging for the program, although the opportunity of developing the National Lung Cancer Screening Program has provided a voice for radiology to federal government as to the utility of this, and it is on the government radar that the sector wants this. It's a unified wish across all healthcare workers who understand and interact with radiology. So that voice is being heard, and I really hope for that landscape to change over coming years. For now, there's no centralised repository, but what there is the National Cancer Screening Register, which will house every report, every one of those standardised structured reports that are produced within the program. So the registrar will be able to provide all the previous reports, and with those previous reports, we know that we can't just compare with the report, we need to compare the images. It will stipulate where it was performed so that there is at least a central repository that will detail out where all of the lung cancer screening program CTs were acquired. All of the peripheral intervening diagnostic CTs performed for query PE and pneumonia and everything else that's happened in between screens, we will be following up the way we already do in routine practice. The GP request is a standardised request form, and one of the fields within that is a detail of any previous CT imaging. So between the standardised request form and the repository of information in the NCSR, we at least have some guidance as to where to go looking. We'll go back to Tom Snow.
Oh yeah, just to say on that point that probably the majority of screening is going to go on in private, and all of the private practices now agree to share access to their packs through IntelliConnect. So as long as you know which packs to look for, you should be able to find the priors. And the problem is going to be if people get screened in public hospital, where it's much more difficult to get a hold of the priors, but we don't think that's going to be much of an issue.
Good note. Thanks, Tom. Sally.
Just one question from the chat. We'll check that's not me. So there's a question from Ellie Moyardi. Where will the MDT sit and who will coordinate and follow up the cases referred to them? How does this work for suburban private practices?
I can answer that one if you like.
Go ahead, Mark.
The GPs will at some point be given lists. So it's up. First of all, it's up to the GP to make the referral to the MDT. In your radiology report, you only make the recommendation, and then the GP makes the referral. And the GPs will be given lists of institutions essentially that offer a lung cancer MDT service. It's not the respiratory physicians sort of working on that at the moment. And once referred to the MDT, the patient is no longer in the program. So the MDT will then organize whatever they think it's appropriate, whether that's a PET scan and a biopsy or further imaging. And the MDT then can only refer the patient back to the program when they're satisfied that all of their findings are benign. We haven't been very specific on what proven benign actually means, and that's kind of going to be left up to the individual MDT. But remember, like not everyone needs a biopsy to for a nodule to be proven benign. Like sometimes, over time can sort of prove that for you. But yeah, so when the MDT is satisfied that there's no longer any evidence of cancer, they'll refer the patient back to the program, and then you start again, basically.
And Mark described earlier the so-called specialist diagnosis form, which is a form that is filled out by the MDT and submitted back to the NCSR to say, this was the outcome of the MDT, these were the investigations that were performed, the participant was deemed to have cancer, not have cancer, and that specialist diagnosis form is then available to the reporting radiologist to access when continuing with future rounds of screening.
Okay, if that is all of the questions, we just have one or two more slides just for general information. I'll just bring them up on our screen now. So we would encourage anybody who is interested in the subjects discussed today to please consider joining ANSTER. Similar to what Sally had up at the end of her presentation, it's open to all fellows and members of RANSCER. There's regular newsletter updates and it's free and fun. So there's the QR code and the link. The next one we have is just a reminder for everyone that webinar 3, the CAD and volumetry software, AI and the NLCSP, is scheduled for next Tuesday, the 18th of February at 6:30. Speakers are Professor Catherine Jones and Dr. Bruno Demusio. And then for further information on all of the other future webinars, please visit the Ransker NLCSP webpage link below. And it's just a reminder for our workshops. Sign up to our nationwide NLCSP workshops via our website. You'll find the registration forms there. And lastly, and most importantly, for our Ransker members, CPD points for attending this webinar will be uploaded to your individual CPD profiles by the Ransker CPD team over the next few weeks, so you don't need to do anything. And then for non-Ransker members, we'll issue a certificate over the next few weeks, and certificates will be distributed. And we'd also like to say a survey will be emailed out to all the participants who consented in the registration forms in the next few weeks, probably after the webinars are finished in April. If you could please give your feedback about the webinars, it'd be much appreciated. And lastly, we'd like to thank our presenters for taking time to be a part of tonight, and we would also like to thank all of you for attending. Have a good evening, and we hope to see you next week.
Thanks everyone for joining us.